Hey everyone, and welcome to This Explainer. Today, we're diving into a medical phenomenon that is equally fascinating and, honestly, deeply alarming. We're talking about a silent threat, hidden away deep inside your body's internal plumbing, just quietly ticking away without you having the slightest clue it's even there. That's right, today we are exploring aneurysms.
I want you to picture the main water line of a massive city. You've got millions of gallons of water rushing through it every single day under immense pressure. Now, imagine a tiny section of that pipe just starts to weaken. It slowly stretches outward, getting thinner and thinner as the water relentlessly pounds against it. Well, that is exactly what happens when the vital plumbing inside your body, your blood vessels, quietly begins to balloon. It's a literal high-stakes structural failure happening right in your chest or abdomen. And as we'll see, the consequences of that pipe bursting are absolutely catastrophic.
Okay, so let's lock down the precise medical definition of our antagonist here. An aneurysm is a localized, abnormal dilatation of an artery or vein that develops whenever there is marked weakening of the vessel wall. Put simply, the structural integrity of your blood vessel is totally compromised. The wall gives way and the vessel just balloons outward. And while this can technically happen in any artery or vein in your body, it notoriously targets the aorta. That's the massive main highway carrying oxygen-rich blood straight from your heart to the rest of your body.
To really understand how this happens, we have to trace the genesis of the aneurysm. Think of your blood vessel as a heavy-duty reinforced pipe made up of multiple layers. Step 1 usually kicks off with severe atherosclerosis. That's the buildup of fats and cholesterol inside the vessel. Moving to step 2, this buildup actually starts destroying the underlying tunica media. That is the absolutely crucial muscular middle layer of the blood vessel. It's exactly like the structural rebar inside a concrete pillar just rusting away. By step 3, without that vital reinforcement, the wall inevitably weakens and dilates under the sheer force of your own blood pressure. And finally, step 4, the aneurysm is fully formed. And what's wild is that a mural thrombosis, basically a blood clot, frequently starts forming inside this new, unnatural pocket.
So, what exactly lights the fuse on this whole process? Well, atherosclerosis is a primary culprit for sure, but it's definitely not the only one. Congenital defects, meaning you're simply born with structural weaknesses in certain arteries, can absolutely trigger this. We also see mycotic aneurysms, which are caused by local infections, and traumatic aneurysms caused by physical injury. Oh, and genetic disorders like Marfan syndrome play a huge role here, because Marfan's inherently affects the strength of connective tissues all over the body, wildly accelerating that wall-weakening process we just talked about.
Now, what's really interesting is the distinct shapes these aneurysms actually take, the literal shapes of danger. We categorize them into morphological types. A saccular aneurysm is basically like a balloon stuck to just one side of the vessel. Cylindrical and fusiform aneurysms are both spindle-shaped, but a fusiform aneurysm involves the entire circumference of the vessel. It swells out and then tapers back down, kind of like a snake that just swallowed an egg whole. And finally, there are berry aneurysms. These are tiny, congenital saccular dilations that literally look like little berries, and you'll specifically find them hanging off the smaller arteries in the brain, like in the circle of Willis.
Let's focus our attention on the biggest battleground, the aorta. This brilliantly illustrates how aneurysms differ entirely based on their location. Down below, you have the abdominal aorta. This is the most common site, driven mostly by that atherosclerosis we mentioned, and it usually balloons out right below the renal arteries. But on the flip side, up in your chest, we have the thoracic aorta. These make up less than 10% of aortic aneurysms, and they have totally different origins. They're often caused by conditions like cystic medial necrosis, where the elastic fibers naturally just break down, or genetic factors like Marfan's or even syphilis.
To really wrap our heads around this, let's look at a typical case. We'll call him John. John is 55 years old, which drops him perfectly into the primary demographic for an abdominal aortic aneurysm. The male-to-female ratio for this is a staggering 5-to-1, and the overall risk spikes significantly after 50 years of age. The scary part? John might feel completely, 100% healthy, totally unaware that the infrarenal section of his aorta, which should normally be about 2 centimeters wide, is slowly expanding.
So how do we spot this threat in someone like John? Well, here is the truly terrifying reality. A lot of the time, we don't. They are largely completely asymptomatic. Sometimes a doctor might literally feel a pulsating mass in the abdomen during a routine physical. If it does happen to become symptomatic, John might start complaining of chronic mid-abdominal or lower back pain. Complications can include the aneurysm actually blocking off surrounding arteries, causing severe lack of blood flow or ischemia to his legs. But the grand finale, the catastrophic climax, is a rupture. If that sac bursts into the peritoneal cavity, it causes unimaginable pain, a massive drop in blood pressure, and death within mere minutes if he doesn't get surgical treatment immediately.
Now, stepping away from John's abdomen for a second, let's look back up at the chest. Thoracic aneurysms reveal themselves in a completely different way. Because the chest is packed tight with vital organs, this aneurysm acts like a balloon inflating inside a very crowded room. It causes pressure symptoms by literally crushing the delicate structures around it. If it presses on the trachea, the patient develops a cough or has a hard time breathing. Squishing the esophagus, that causes dysphagia, or difficulty swallowing. If it compresses the left recurrent laryngeal nerve, the patient's voice suddenly becomes hoarse. And if it crushes the superior vena cava, blood backs up entirely, causing noticeable swelling and edema right in the neck and arms.
So the doctors suspect a problem. How do they actually map out this hidden danger? They really have to become detectives here. If they suspect our guy John has a mass, an abdominal ultrasound is the go-to diagnostic tool. It's quick, it's effective. But to plan a complex surgical strategy, the surgeons need precision. They'll use contrast CT scans or MRIs to define the exact extent of John's aneurysm. And in some cases, an aortogram is necessary to map out the entire arterial tree, especially if they think the visceral or lower extremity arteries are also blocked up and need repair at the same time.
All right, let's talk about the surgical red lines. When does a doctor finally decide, okay, we need to open this patient up? For an asymptomatic abdominal aneurysm, this is the magic number right here, 5 centimeters. Keep in mind, a normal aorta is roughly 2 centimeters, and aneurysm is technically present at 4 centimeters. But once it hits that 5 centimeter mark, the risk of that structural pipe bursting completely outweighs the risks of the surgery itself. Surgery is advised. That is the number John's doctors are watching like a hawk. Now, for a thoracic aneurysm up in the chest, that general threshold jumps up to 6 centimeters, or if they notice it's growing rapidly over a really short period. However, and this is critical, if a patient is symptomatic, meaning they're experiencing pain or those crushing pressure symptoms we talked about, repair is indicated immediately, no matter what size it is. But the rules change drastically based on exactly where the aneurysm is located and what underlying conditions the patient might have. For instance, for aneurysms specifically located in the ascending aorta, that's the part immediately exiting the heart, the margin of error is a lot tighter. Medical guidelines strongly recommend these be resected when they reach just 4.9 centimeters. And this really shows how genetic and structural factors shift the entire math of the situation. If a patient has a bicuspid aortic valve, which is a congenital heart defect, combined with aortic insufficiency, their tissue is just inherently more vulnerable. For them, the threshold to step in and defuse the bomb drops even lower, down to 4.5 centimeters. The danger is simply way too high to wait.
So context is absolutely everything here. Listen to this number, 4.3 centimeters. This is the absolute tightest surgical threshold we see. If a patient has Marfan syndrome, their connective tissue is genetically weakened from birth. Their blood vessel walls are profoundly fragile. For those patients, an aortic size greater than just 4.3 centimeters warrants immediate surgery.
Once that threshold is crossed, whatever it happens to be for that patient, we reach the dramatic surgical climax, diffusing the bomb. The only way to fix this failing biological pipe is to go in, literally turn off the waterman, cut out the weakened section entirely, and swap it out for a durable synthetic one. The standard procedure involves surgical excision of the aneurysmal portion of the aorta and replacing it with an artificial, highly durable synthetic graft, which is often a Dacron tube. It is a massive, life-saving structural renovation of the human body. But wait, what if the aneurysm hasn't actually reached that red line yet? Say John's aneurysm is sitting at only 3.5 centimeters. How do we slow the ticking clock? Well, long-term medical management is absolutely essential. The ultimate goal is to lower the physical pressure hitting that weakened wall day in and day out. That means rigorous control of hypertension, or high blood pressure. It means strictly avoiding smoking, because that damages the blood vessel walls even further. And crucially, it involves the use of beta blockers. These slow the heart rate down and lower blood pressure, which is clinically proven to be associated with a decreased rate of growth of the aneurysm. Because if an aneurysm goes totally undetected, or if medical management fails and the surgery isn't performed in time, we arrive at the incredibly grim reality of the final complications. The aneurysm can severely crush the surrounding tissues, blood clots can form inside that sac, break off and cause severe ischemia by blocking vital blood flow to the limbs or organs. Worse, a dissecting aneurysm could rupture right into the pericardial cavities surrounding the heart, causing immediate cardiac failure. But the ultimate consequence is a full rupture, leading to massive internal hemorrhage and
inevitably, death.
Aneurysms truly are a masterclass in the body's hidden vulnerabilities. They develop so slowly, silently destroying the foundation of our internal arteries right up until the exact moment they fail. It brings up a rather unsettling realization about the machinery we rely on every single second of our lives. Since the most dangerous aneurysms are completely asymptomatic, hiding totally out of sight and out of feeling, I'll leave you with this. How confident are you in the silent plumbing of your own body? Thanks for joining me on this explainer. Keep learning and stay curious.